So I was going to talk about masks in the age of COVID-19. There's a lot of conflicting and confusing statements that are out there, and I thought I would just clear the air and talk a little bit about this disease. Maybe a little bit of background first. So this is the SARS-2 virus. It's actually, the official name is actually the SARS-CoV-2, and it's because it's very similar. It's a cousin to SARS-1 that we all heard about that didn't really impact our country, but genetically very, very similar. In fact, even attaches to the same receptor in the body. It's highly infectious with an R naught of approximately 2.5. And I'm going to go over what R naught means because it's going to play into why we want to talk about masks and some of these other mitigation strategies. So the ACE2 receptor is this protein that lives on certain cells in our body, and it's basically the doorway for the virus to enter your cell. And where these ACE2 receptors exist sort of gives you a clue of what type of clinical syndrome you should expect from this disease. So certainly it is on the respiratory tissue, which is why this was initially called a pneumonia. But we know it's far more than pneumonia now. And it is that this receptor actually does exist in the eyes, which is why eye protection is actually quite important. You can, in fact, catch this, and that's been shown in animal models, that you can deliver this virus to the eye, and it can attack the body through the eye. The receptor also exists on the heart, kidneys, gut, and other organs, which is why we're seeing cardiac symptoms, kidney symptoms, and a lot of GI symptoms with this. So these are some of the classic symptoms. I think this should be very familiar to everybody by now. You get a low-grade fever, headache, cough, shortness of breath. You get a lot of abdominal stuff with this, diarrhea, nausea. Altered sense of smell and taste is one of the things with this. And here's one of the big ones that we missed, I think, initially in this epidemic, but I think we're getting a handle on it now, and it's making a little easier to treat these folks. There's a lot of blood clotting issues with these folks. So some of these folks will actually have an abnormal extra clotting ability, and some will actually have a hypocoagulable, meaning that it's very easy for them to bleed out with this thing. And they go through this sort of a progression, where one patient can go through a stage of being normal, having a hard time forming clots, and then being a super clotter, where we have to put them on blood thinners. So now we're knowing that we need to follow those blood tests and make sure the coagulation system is in order and give them blood thinners like heparin, for example, if necessary. ARDS is certainly a part of the problem, as well as cytokine storm. And that's why we started treating these folks with immunomodulators to decrease the cytokine storm. That cytokines are released when the body fights an infection. That's normally a good thing. But when you get too much of it, then you get so much inflammatory response that actually damages the organs. And that's what we see in ARDS. And sort of turning off the immune system a little bit helps mitigate that. And the latest thing we've been seeing, and you may have seen in the news, is this Kawasaki-like illness that we're seeing in children and young adults to like their mid-20s. This is normally a pretty rare illness, but we're seeing it far more common with this particular disease. So treatment-wise, remdesivir has been proven to be helpful. It is now considered the standard of care for anybody who's hospitalized with an O2 sat of 94% or less. Earlier works better. This is a medicine that prevents the virus from replicating itself. So sooner is better to decrease the viral load in the body. Oxygen plays a big role in this. In fact, some of the things we shied away from in the beginning because of aerosolization and risk to healthcare providers is actually been proven to be one of the things you should do, which is high flow nasal cannula, CPAP, and BiPAP. But obviously you have to do those in an environment that mitigates the risk to the healthcare team. Just positioning these folks in the prone position or lateral position has been shown to decrease their need for ventilator use and raises the oxygen level. And what we found is that we really want to do everything we can to decrease the chance that we're going to intubate these folks. You really want to hold off on intubating these people. And it's developed, we see this clinical syndrome called the happy hypoxemic patient, where their O2 sat is quite low, but they're tolerating it quite well. So you should try to avoid intubating these folks because the barotrauma from the ventilator actually causes additional damage to the lungs and a very high, unacceptably high mortality rate. That's the blood thinners that I mentioned before. And then convalescent plasma. For those of you, that are doing Dr. Jameson antibody test, if you find that you've been immune, you may potentially be actually a donor for convalescent plasma, where they take blood from you, filter out the antibodies that fight COVID, and can use it for those that are very sick. So a little update on the vaccine. There are several that are in development. There are two that have caught my eye. One's AstraZeneca, which is using a platform based out of Oxford. It uses an adenovirus that's very benign to humans, and they've inserted the messenger RNA for the COVID-19 spike protein, and that's progressed to phase 2 trials. And then the Moderna, which is out of Massachusetts, which creates this, it's pretty brilliant technology in my mind, sort of a human-made virus-like particle. It's not a virus. It's just like a little lipid ball that they insert the messenger RNA of only for the spike protein. Now, the spike protein is what the virus attacks our cells with. It's how it attaches to the ACE2 receptors. And if you can create antibodies to that, then you can theoretically prevent yourself from getting infected. And both of those are now in phase 2 trials, and both are being fast-tracked. And it's possible, assuming that, now obviously there's some hoops they got to jump through, but it's actually theoretically possible that we could have a vaccine from one of these two candidates in the fourth quarter of this year, at least for first responders and healthcare workers. You know, they'll have to ramp up production for the entire population. Now, mitigation strategies, that's what this talk is really about. So until we have some of those other things I was talking about, like the vaccine, we need to reduce the effective R naught of this thing. Now, the R naught is basically the average number of new infections generated by one infected person. The typical flu is in the low ones, like 1.3, 1.4. The 1918 pandemic flu that killed tens of millions of people worldwide had an R naught of about 2.3, 2.4 range. So an R naught that's less than 1 means the infection will die out on its own. MERS had that. MERS had an R naught of 0.75, and it just kind of went away on its own. When the R naught is 1, the infection is stable, meaning it won't go up, won't go down. It's just one person infects one person, and it just stays the same. R naught greater than 1, the infection continues to grow and spread. And the higher above 1 it is, the more exponential growth that you will see. So typically one person infects 2, so with R naught it's 2.5 is their R naught. And you'll see as it grows, one person infects 2.5, and that next person infects 2.5, and you really get this exponential growth over time. So that if you started off with 100 people on day 1, within a month, you'd have tens of thousands of cases with an R naught of 2.5. That's why mitigation is very, very important. If instead you could use mitigation to reduce the R naught to 1, then you stay stable. And those 100 cases you started with are still 100 cases at the end of 30 days. And that's what we're trying to do, is what can we do prior to a vaccine to reduce the transmissibility of this particular virus? And it all has to do with multiple steps that we use together. So obviously we're familiar with mitigation measures such as shutting down society and avoiding all human interactions. That's very, very costly to society and creates all sorts of other problems. Our schools were closed, our businesses were closed, lots of people were laid off. But did it work? Yeah, it worked, because you starved the virus of new hosts that it could infect. So that did get our case load to calm down, but obviously that's not a sustainable model. So what else can you do? Washing your hands, because we know if you touch surfaces that are infected with COVID-19 and then you touch your eyes, theoretically you could transfer it. Obviously, you want to clean the surfaces themselves. So anything that's a high-touch surface that might have been contaminated by those that are infected, you clean those down. You want to maintain that social distancing, and we're going to talk about that 6-foot thing, and is that really enough or not? And then, of course, you don't want to touch your face or eyes if you've been touching things that are potentially infected. Now, those are all fairly well accepted in our society. But the last one is masks. And for whatever reason, masks have become a little point of controversy. And I'm not really sure why. So I'm going to go over the science of this, and then you make your own decision. But masks, especially in areas where you cannot distance yourselves, and especially when you are indoors, because we find that outdoor air is far, far less infective than indoor air. And that simply has to do with dilution of the virus. But when you're indoors, it's really pretty important to wear masks, and you're going to see why. So for respiratory protection, now we're talking about PPE, personal protective equipment, and then we're gonna translate that into the use of cloth and homemade masks and see where we're at. So you have these elastomeric half face pieces. That's where it doesn't cover your eyes. It filters out the air that you breathe. It goes through your nose and your mouth. And then the next one, you've got the full face piece that covers your eyes as well. You've got these disposable N95s, and then you've got the powered air purifying hoods. Those are particularly good for folks with facial hair because you can't get as good a seal. And then you've got the various types of apparatuses that have their own air source, either through a hose or through a SCBA tank or through some combination of the two. And those things, as you go down that list, you get higher and higher assigned protection factors. And basically, an assigned protection factor, the higher it is, the more contaminated an airspace you can get into and still have protection. Meaning, so just roughly translated, an APF of 10 means whatever it is you're trying to protect yourself from. If 1 is an acceptable level of that thing in the air, if you have an APF of 10, you can have a concentration 10 times the acceptable level, and that thing you're wearing will protect you from it. So obviously, you get all the way down to 10,000, you can be a highly contaminated environment, and you're quite safe. So what about this terminology, the N95, R95, P95, 100, et cetera? So here's a quick primer on that. N means simply no oil resistance. R means it's got some oil resistance, and P means it's strongly oil resistant. Now, we don't really need oil resistance in medicine, but does it mean that you cannot use an R95 mask or P95 mask? No, it doesn't mean that. It just means that in addition to what N gives you, it also gives you oil resistance. And then the 95 means that it filters out 95% of particles that have a 0.3 micron size. Now, I see a lot of sort of misunderstanding of what that means. That means it doesn't filter things larger than it? No, it doesn't mean that. It doesn't mean it doesn't filter things smaller than that. No, it absolutely doesn't mean that either. It just, that 0.3, as I'll explain a little bit more, is the most difficult size of particle to filter. So if you're filtering 95% at 0.3, that's really good. Now, a P100 or N100 just means it's a 99.9% filtering of 0.3 micron size. FFP, you may see with FDA language, that's a filtering face piece respirator. So how big is coronavirus? So we talked about filtering at 0.3 microns, but the coronavirus is only 0.1 micron. So it's quite a bit smaller. So that means that an N95 mask doesn't filter that? The answer is yes, it does filter it. Because first of all, the virus when you cough it out or somebody speaks and the virus goes into the air, the virus isn't out there as a naked virus. It's in there with mucus or saliva. It's a much larger particles already anyway. But when we get to how particles are filtered out, there's a few different ways they're filtered out. Number one is the fiber is simply a physical barricade, like a car barricade. It stops it from going through. Those are your larger particles. And then for your really tiny particles, like coronavirus, for example, things less than 0.3 microns, those particles are so small that they don't go in a straight line. They zigzag because they're so small that simply collisions with air molecules cause them to alter their mass. And since they go in a zigzag, they typically get caught up in filters all the time because they can't go straight through. So they run into the fibers all the time. And then the last type of filtering is this thing called electrostatic attraction. You can think of it sort of like a magnet. Some of these particles have minor charges on them, either positive or negative. So if you got charged fibers in your mask, that also helps with attracting these things so it doesn't get through. So the physics of this is that larger particles will be blocked simply by the physical fibers of the mask. Smaller particles will run into those fibers anyway because they zigzag through. And the most difficult fiber, the ones that are most likely to zig a little bit, but not quite enough that it gets catch by the fiber, happens to be right at 0.3 microns. So that is why, if you look at the graph, that is the most difficult particle size to filter out. And that's why it keeps saying 0.3 microns. That's not to mean that that's all that it can filter. So I'm just going to quickly show a video here, and I sped it up a little bit on how you dom these things. Now, obviously, it's going to depend a little bit on the maker of the mask, but you put this on your face, you put the top strap first, and then you're going to take the bottom strap and put it down. You're going to make sure that you got a good fit. And one thing I want to show you here is that when you get to the nose piece of this, you're going to push it down with both hands equally. Because when you do this pinch with your thumb and your forefinger, it doesn't give equal pressure, and you're more likely to get gaps. And it's critical for these N95s that you get rid of the gaps on that thing. And then taking it off is really just as important because you want to make sure that when you're taking this off, you don't contaminate yourself. So you're going to do the opposite. You're going to take the bottom strap off first. So remember, the bottom strap is first off. And when you're going it off, and then you take the top strap. And so it's the exact opposite procedure. And then you take it away from your face as you do that without touching the contaminated mask. Wash your hands both before and after you touch that mask. Now, we know that keeping EMS safe is part of the goal here. And in the beginning of this pandemic, we were having issues with folks getting contaminated on the job. And in New York, they sort of taught us because they got the wave a little earlier than us. And we were getting reports where EMS was going on these calls where people had no COVID symptoms whatsoever. This is before we realized all the asymptomatic carriers of this virus. And they'd go to somebody for a broken shoulder, for example, and they'd bring him into the hospital not wearing any PPE because they're like, oh, he's got no COVID symptoms. Sure enough, the patient would have a broken shoulder and they've got COVID. So we were getting a lot of EMS exposed, and we changed across this country the policy that now we wear PPE every call, every single time. And we saw from many cities across this country that the exposed EMS staff really, really dropped with that policy. Now, the other thing we learned was that folks who were starting to wear the PPE at all times, even in the station, we really dropped the risk of catching this stuff on the job. And we started seeing that these folks, when they did catch it, they were catching it at home from their family members. And you actually saw that in Wuhan. You saw that everywhere, where people were forced to stay at home. They were catching it from the people they were living it with. So you have to understand that this is not just something, a protection you do on the job. This is something, protection you do during your entire life until we get that vaccine ready to go, or until most of the population has already been infected. Now, we know there's not enough masks, so we've come up with a bunch of technology to clean masks. This is the vaporized hydrogen peroxide. Battelle has a contract with FEMA to do this all around the country. We have that actually here in Florida as well. And that does, in fact, clean the masks out pretty well. The other option is to use these ultraviolet C lights. Now, keep in mind that ultraviolet C often does not make it through our atmosphere. So these are special bulbs you have to use. This isn't just laying it in the sunlight. You have to use these special bulbs that have a specific wavelength. And you want to make sure it's actually specifically ultraviolet C, because there's ultraviolet A, B, and C. You want the C. And N95decon.org has pretty good information on both those decon things. And the last one is what the CDC puts out. There was a study on how long does the virus live outside the body on various different surfaces. And when you look at cardboard, which is the closest to our N95 mask, it can last for, after 48, 72 hours, most of the virus is pretty much dead. So their recommendation is, if you have no other thing, let the mask dry out. Now, some folks have been storing these masks in plastic bags. That's an error, because there are certain things that allow the virus to live longer, such as colder temperatures and moist environment. So you want warmer temperatures and dry environment. So paper bags for these things if you're just going to be doing the wait time for the virus to die technique. So social distancing. We're going to move away from standard PPE and start talking about the other mitigation factors. So is 6 feet enough? And it turns out, when somebody sneezes, that thing can go like 23 to 27 feet. And here's a quick video. And this is at 20 inches. This is somebody sneezing, and that's all the particles coming out of their mouth. Now, a lot of these are not visible to the eye. Now, here it is at 43 inches. So you're standing a little bit further back, but you can see that easily reaches you at 43 inches. This last one is at 26 feet. And you see at 26 feet away, you're still getting a cloud of these viral particles into your face. So what could block that? Well, masks, perhaps, right? So there's a widely circulated study about hamsters and masks. Now, the hamsters did not wear a mask. They also didn't socially distance well either, but this was their method. They did this in Hong Kong. They took a fan and they put it on the cage with a bunch of hamsters, which, by the way, hamsters have the ACE2 receptor. They can be infected with this COVID virus. A lot of mammals have the ACE2 receptor, which is why it can cross into different species. And they blew the air from the infected hamsters over to the non-infected hamsters' cage. And they found that when they did nothing, they had a 66% infection rate of the uninfected hamsters, with a pretty high viral load in these folks. And then what they did is they changed it, and they put a surgical mask filter on the cage of the uninfected mice. So as if those mice were wearing, hamsters rather, as if those hamsters were wearing a mask. And what they find was a much lower infection rate, and the ones that did get infected had a much lower viral load, which is important. The lower the viral load, the more likely to have a benign clinical course. But then they did one more thing. They changed the mask and they put it on the source, something called with the CDC terms source control. Remember that sneeze that I just showed you? Now, if that person wearing the sneeze, that keeps that whole thing in. So now you're not really contaminating the environment so much. So it's not so much to protect the source, it's to protect the rest of the world from the source. And that's what dropped the infection rate down to 15%. And of those 15%, they also showed a much lower viral load, again, because you're decreasing the infection in the environment. So there are not enough medical masks for everybody. So what about cloth and homemade masks? Are these things useless? Well, they're certainly not considered PPE. They're not up to PPE standards, but do they have any value? Well, here's the thing. People are going out and saying, well, why should I wear a mask? I'm not sick. Well, the thing is, we know that a lot of people, they don't get ever any symptoms, yet they're spreading this disease. In Iceland, they tested a large population, a large section of the population. They found that the folks that were positive, half of them never had any symptoms whatsoever, yet they were still contagious. The Princess Diamond, that made the news quite a bit, right? Remember all those folks who were on the cruise ship? Well, they found the people that were positive there, 46.5% of them never had any symptoms, yet they were spreading the virus. So this asymptomatic spread thing, this is a real phenomenon. There's a study by Lee et al., and I put the reference there. Asymptomatic cases, they were less contagious, but they accounted for 80% of the spread because there's so many of them out there. So these folks are walking around coughing, sneezing, and even just speaking for 5 minutes puts a lot of virus into the air. So the cloth masks, there's a number of Or cloth masks needed for everybody. So surgical masks will decrease the exhalation of viral particles by 3-fold. Now, we don't have surgical masks for everybody, but this is that source control the CDC talks about. Again, trying to keep you from coughing or sneezing or even speaking viral particles into the air. When we talk about all these mitigation things, they are additive. So, for example, if you look at a car, right? A car with no seatbelt, no airbag, you're at high risk. You put the seatbelt on, that decreases your risk. You put a seatbelt plus an airbag, that decreases your risk further. All of these things add up together, and it's the same thing with all of our mitigation strategies. So when you have a mask on, now I don't have to wash the surface as much because I'm not coughing or sneezing on it or not breathing on it. I don't have to worry about hand wash as much because the surfaces aren't as dirty. I don't have to worry about touching my face as much because I got a mask reminding me not to touch my face. So you see how these things can sort of add together. Now, the R naught, back to the R naught, you remember that number, the exponential phase. So there are some epidemiological studies out there, pretty interesting to look at. And if we have enough people wear masks, even lower efficiency masks like these cloth masks, and we can get to 2.5 down to 1.35, and we start off with 100 cases today, that's a difference of having like maybe 500-600 cases in a month from now to tens of thousands of cases in a month from now. So it's a big deal to be able to get this R naught down. So, and in fact, in some of these models, it shows that if you have a high efficiency mask and everybody wears it, or at least 80% of the population wears it, you can make the pandemic go away. So now these are epidemiological models. So, who knows if that will work in real life, but here's a graph. Here's an example of these models. And this is using, by the way the COVID pandemic has rolled out across the world. And you can see here, if you get 80% of the population wearing a mask that is only 50% effective. Now remember, the surgical mask was close to 70% effective. But if you get at 50%, you basically make the pandemic go away. And anything lower than that, like say 40% effective, that actually reduces that flattens the curve tremendously. Now, this is assuming that nobody does any other mitigation strategy. So this is mask alone, according to this model, which is pretty cool. So how do cloth masks work? So there's two things you want to do. You want to have that barrier, that physical barrier, like I mentioned, and then you want to add electrostatic filtration if you can. Here's some studies that are actually done on various cloth masks. And cotton is definitely big up on the list. It's comfortable to wear. It's highly available. And what we found is that high thread count cotton is very good. Low thread count cotton, not so much. And if you combine things like multiple layers, like here's silk, which you would imagine silk wouldn't do a good job. But silk actually has a lot of electrostatic abilities. And when you do 4 layers of silk, it actually starts getting up to be pretty efficient. But then you start thinking about combining fabrics. If you can use the electrostatic properties of silk and combine it with the barrier of cotton, you know what? You're about as good as an N95 mask now, which is really pretty interesting. Now, this on the filtering standpoint. It doesn't mean that you got a good fit on the face. So what we notice is that these homemade masks, they have a lot of gaps. And when there's gaps, the air entrains themselves around the sides of the mask, and it really decreases the efficiency. So what can you do? A simple technique. You just take some sort of elastic thing, like here they're using actually a nylon a nylon stocking and cutting it so that it form fits over your face as an extra layer over your cotton mask that now allows it to form fit and gets rid of a lot of those gaps. And when they did that, they really tremendously increased the value of these homemade masks. And now you've got a very highly efficient mask that you can use with readily available stuff that the entire population could wear, and it's quite comfortable. So here's the conclusion before we get to the question. We'll open up the questions. So SARS-CoV-2, very contagious, deadly disease. Even if you don't die from this, it gives you a far worse clinical course for the folks that get sick than typical respiratory infections. Asymptomatic spread, it occurs widely. You could be having this with no idea you've got it and go out and spread it to everybody. The mitigation measures, they are effective. Each of them individually are effective. And when you combine them all together, they become more effective. They are additive. Masks likely reduce the risk both for the wearer and for others. Keep in mind, let's say, just as an example, I had a mask that was only 50% effective, and you were wearing a mask that was only 50% effective. Well, now we've got a team of masks. My mask will drop the viral load by 50%. Your mask will drop it by another 50%, which means you'll be down to 25%, so for 75% efficiency. Now, if you add to that, you're more than 6 feet away from me. Now you're really starting to get some good mitigation methods. Widespread use of masks are likely an effective means to reduce the transmission. Combination of high thread cotton and silk or chiffon are actually highly effective, and you got to do some tricks to reduce the gaps when you're wearing these things.